Okay, I'm going to get us started because it's 12:07 and I have lots to say. I have lots to say. So here comes Teresa. I think she's going to introduce me technically.
Hi, everyone. Welcome to seminar. We are very excited to have you both in person and virtually. Thank you for joining us today. We have Karen Farris here, who is our, I see. Hi, everyone. We have Karen Farris, who is a full professor at the University of Michigan in the clinical pharmacy department. Karen is a world-renowned expert in medication adherence and conducts research in primary care. I've known Karen since 2009, but Karen's career has been researching pharmacy practice for over 20 years or maybe more. But and so
20, yeah, 20, everybody.
20 years.
20. Yeah.
So we are very privileged to be able to welcome you here to VCU and to the CPPI seminar series. So without further ado, I'd like to turn it over to you and thank you for being here.
Thank you. Thank you for your presence in the room. And I see people's names online that I know, and I'm happy and honored that you are there and want to hear about some of the work that we're doing at the University of Michigan. So let's make sure I can get the technology going here. So some of you will know how many years I've been doing this work, but in the end, you will figure that out. So let's see, I hit the down button. Nothing happens. Let's hit the enter button. Nothing happens. I was doing this button. Okay, I'll just click. I'll just click because I'm going to stand right here.
There we go. You should be able to use the arrows right
Okay. I didn't do the down. Okay, got it. Okay, so this is something that I need to share with you for your CE, and you will see that I have an AstraZeneca grant that I need to disclose. Right. You can see it right there. And then this is the information that I believe you need for your CE. So I will leave that up there just for a moment. And I think the important thing is 25380-25376. Okay, everybody got the number? And we can always go back to it at the end. Okay, I want to disclose or share with you the funding that supports the work that I'm going to share with you today. So I work with one of my former graduate students, Justin Gatwood. He's now at the University of Tennessee, and we're working on oral anti-cancer agent adherence, so OAA adherence. I work with a terrific colleague, Haimee Cho, who some of you know, and she is the director of quality now in our medical group at the University of Michigan, and she and I are working on our CDC 1817 grant, which is pretty small, focused, and kind of cool. So I'll tell you about that. I work with Emily Mackler in POEM, which is Pharmacists Optimizing Oncology Care Excellence in Michigan. That's a mouthful, but POEM. And in Michigan, we are privileged and blessed, honestly, for lack of a better word, to have Blue Cross Blue Shield of Michigan support numerous quality collaboratives across the state. And one of those is POEM. And then the last one is I worked until 21 with Moxie, and now we've transitioned to POEM in terms of that work. But I did have work with Moxie before POEM, and I wanted to disclose that. So these are the objectives for your seminar. I believe you've seen these probably every week, and I suspect that every speaker has a take, for lack of a better word, on these. And so you're about to see my take on these objectives. So because I've had so many years doing research, I'm wanting to share with you some lessons learned over my time, as well as even some lessons learned in the current studies that I'm going to be talking about. So what are lessons learned? Those are experience distilled from past activities that we should take in account as we go forward. So what have I learned in my past that I want to use in my future? Or what are some things I've learned that you might think about as you're on your research trajectory? So this is Karen Farris's view. Okay, Karen Farris's view.
They're not viewing the full.
It's okay. You keep going.
They're not viewing slides, I believe. So Madeline is
They can-
working.
They can see this.
Okay.
They're seeing the wrong one. That's
Oh,
okay.
Madeline's
Go
working
ahead.
on
Go.
that. So I'm going to keep going. So this is a complex chart. It's a 4x4 chart. So there are it's a 4x3, sorry. So there are 4 objectives. And then across the top for each of the objectives, I've identified structural issues, process issues, and outcome issues. And if you've ever been around me, you know this is kind of the way I think, right? What are those things that are in our system that help us deliver? What are the things we actually do, the processes? And then what is it that we're held accountable for? Those outcomes, whether they're patient or health system outcomes. And so I've taken the 4 objectives and identified some issues, structure, process, outcomes. Is this a comprehensive list? It's not too bad for right now, meaning for 2022. I think it's got some timely topics on it. I'm going to go through each one of these pretty quickly because I do want to talk about some cool research that we're doing. But I do want to highlight that what I am going to be talking about is right here. These 4 dark blue, it's hard to see, but they're dark blue. So I'm going to briefly run through these. We've got some questions related to these objectives, and then I'm going to talk specifically about these 4 dark bullets. Okay. My button wasn't going forward, so I'll just use that one. Okay, so this is just the top row. What are some of these changes in healthcare delivery that impact pharmacy practice? I would say among the most significant is HIT, Health Information Technology, the EMR, where how that affects all of the work that we do, whether it's in a community pharmacy, primary care, specialty, inpatient, it's significant, as you all know. I've got other things listed there as well. In terms of process, I do think that there's a growing prevalence of team-based care. You see pharmacists in primary care, you see pharmacists in specialty care. Of course, historically, we've seen them on rounds in the inpatient setting, but we're really making significant inroads in the ambulatory space. And with COVID, honestly, that's just helped us, right? Because we've been given permission to use telehealth, for lack of a better term, given permission. And so we've got new structures now that enable that. And I think there's just so many opportunities as we move forward. And clearly we now have new reimbursement mechanisms, particularly on the ambulatory care side, but even VBR on the inpatient side. So those value-based reimbursements for reducing rehospitalization, but we've got quality metrics on the ambulatory side. So those are important changes in healthcare delivery that impact us. So these are some current trends in contemporary practice. And so I'm just listing them here. I'm not going to spend a lot of time on them because I do have to keep moving forward so that I can talk about some of the work that I have. We are reimagining our Center for Interprofessional Education as we move forward at the University of Michigan. And I'm very excited that I'm going to help lead the research efforts around IPE. So I know you guys have got some great stuff going on. So I will be probably circling back with a few of you to talk about that as we move forward. I think on the process side for pharmacists, you can see here some examples. I would say, at the University of Michigan, we're still in a disease management for our primary care pharmacists rather than CMM, which you'll hear from ACCP. So there's some, I don't know if controversy, but there's a tension. There's a tension between that, I would say. And so we need to move towards CMM so that we're looking at that whole patient, not just a few clinical outcomes. So this is your third objective. practice innovations designed to lead to health improvements. So this is a model, optimizing care model with technician product verification. So folks, we're going to have increasingly pharmacy technicians take on important roles in our pharmacies, whether they're planning, talking with patients, setting up the pharmacist to do the clinical work. And so we've got to embrace that. I'm sure that those of you on this call are, but we're just going to see that grow. So these are the 4 things I'm going to talk about here in just a moment. We do need to be thinking better about that ROI for pharmacists. We've kind of always talked about it. Teresa was talking about it today, that the center is moving toward having a model to develop that ROI for one of the healthcare organizations here in town. Certainly, we're thinking about it in our 1817 project, even though we have small numbers, we're still thinking about what is that pharmacist billing? What can he or she do to support part of their salary as they're in their clinic? And then our 4th objective is discuss role delineation. Okay, so number 1, let me apologize for using the word stupid. Okay, but if you're as old as me, you know where that comes from. Nobody in this room is as old as me. Oh, Dave Holford is. Oh. And there are a few people online who are as old as me. So remember, it's the economy, stupid. Anybody remember that? Okay, that was a Bill Clinton thing and his advisor guy, James Carville, whoever. But I have heard and been around some pharmacists who are talking about other clinical services. And there is nothing wrong with doing other kinds of things that maybe aren't quite as medication focused. But I guess my advice, whatever the right word is, my lesson learned would be, we are pharmacists. They come to us because we know the meds. It's the medications. So like stay focused on your outcomes derived from medication use. Okay, so that's really a message that I feel, as you can tell, pretty passionate about. And that's not to say there aren't other things that are important, but we are pharmacists, we are about the meds. So that's what that means. And so I apologize for using the word stupid, but it was like the funniest thing I could think of at that moment. And so there you go. I do think that we're making some tremendous headway on state laws around provider status. We know that there are states around the country that have been successful doing that. I have a little bit of a quick story around the Michigan perspective, which is interesting. That's what I would say. It's interesting. And so we're beginning to work in this space, but it's interesting. And when I say outcomes, what team, what I really mean is those outcomes are going to vary if you're on the inpatient side, if you're in primary care, if you're in specialty care. Know what your quality metrics are, know what your practice is trying to achieve, and figure out how your medication use outcomes inform those metrics, move those metrics. The other thing around that I just popped in my head, to be quite honest, is that, there's the quadruple aim. So how do you as a pharmacist help your clinic feel better about all the work they have to do? Because I know that you can. Okay, so it's not just about lower prices or lower costs of care. It's not just about improved quality, but it's also about how is our workforce feeling and how can we as a team deliver positive care. Okay, so that's what I see from your 4 objectives and how they relate to pharmacy practice. And so now we have a couple questions, okay? And then we're going to get to the 4 areas that I want to talk with you more in depth about. So your first question, remember structure, process, outcome. So which of the following is a structure characteristic related to changes in healthcare? A, B, C, or D? And I think those of you can put it in the chat, or someone can yell it out to me. And Ben is telling me to preach. Thank you, Ben. Anybody, A, B, C, or D? What does anybody in the room say? A. Okay. Oh, somebody said C. So I think a primary care pharmacist ROI is not a structural component because it's not an underlying thing that we have to deliver care. Rather, it's a function of process and outcome. You get that ROI by knowing what the pharmacist does and the impact that the pharmacist has. And what's critical is that there's this foundation of structural components that allow that pharmacist to deliver care and have the outcomes that they can have. So A is the correct answer here, structural component. Okay. Oh, I'm sorry, I'm pushing the wrong button. There we go. Okay. You have one more question right now. Which of the following, students love these kinds of questions from me, just so you know. They really don't. Which of the following is true about current trends in interprofessional collaboration? A, transitions of care help connect patients back to primary care. Yes. B, IPE training is widely seen in schools and colleges of pharmacy. Yes. So therefore, you already know the answer. C, COVID vaccines have likely raised pharmacists' profile or role among providers and patients. Yes. So the answer is D. Okay, all of the above are true. Okay, so that gets us through two of our objectives. Okay, but now I want to focus on some things I've learned. Oh, take it away, right? Okay, I moved it. Is that okay? All right. Sorry, folks online. I apologize. Thank you, Madeline, for directing me. So I'm going to talk about three things: lessons learned in linking community pharmacy and primary care, linking primary care and specialty care, and then remote BP that we've just started. Okay, so those are three things I'm going to talk with you about. So let's, hitting that button, it doesn't work. Here we go. Okay, so linking community and primary care in our CDC. So we have a CDC 1817 project. We just started ours, and we did not start in year one because, to be candid, we did not have a relationship with the Michigan Department of Health and Human Services. They kind of heard about the work going on in Michigan in primary care, approached us in year two, and then they had some, honestly, some extra funding, some funding they could direct our way to do some work in years 3, 4, and 5 of the 1817. So right this second, we're in year 4, right? Which is really year 2 for Michigan, okay? All right. So the basis of our 1817 project is this work that we did with CVS, as well as this work that we did with Meyer. So the first work in CVS was we took 2 CVS pharmacists, we brought them to Michigan, we trained them on our primary care model. We put them about a day a week in our primary care practice and a day a week in their pharmacy to see patients. Okay, we had funding to support that. So we started that with CVS, and what we learned is, well, that's too much. It's too much. The business model on the pharmacy side could not manage 2 days a week. And to be real honest, the roster or the number of patients that we shared was not high enough to warrant 2 days of practice. Okay, so in the Meyer model, so we were partnering with a grocery pharmacy that's based right there in Michigan. And so we have about a half day a week where a Meyer pharmacist sees patients from a Michigan medicine clinic for their hypertension control. And those pharmacists in Meyer have access to the EMR. And let me be really clear, that took a year because it did. Okay. It took a long time from the institutional perspective to let go of that information and to go through all the hoops to have the pharmacists have access to that. Now, those pharmacists in Meyer do not practice under a collaborative like our primary care pharmacists do, but they tee up, for lack of a better term, recommendations for a physician to accept, okay? Well, and I should say, what this paper showed is that they produce equivalent blood pressure outcomes, and they're positive and improved. And I should say that, share that. So in our 1817 project, we are working with 3 rural sites. So we are here in Cadillac, Gaylord, not Gaylord, Gaylord, and Charlevoix. Okay, so these are places, these are communities. These 2 are around 8,000. This one is around 15. Okay, so, and they do have some hospital access there. What we are working with is a single physician organization that has those 3 systems included under it, but they all have different EMRs. So it's not like, oh, we can train a pharmacist and they know how to do everything in that EMR. No, can't do that. So here's what we've done. So we took a medical clinic and we have a pharmacist who works there 1 day a week. Okay. In year 1, we also took a pharmacist from a community. This is just a clinic pharmacist. She only goes to clinic. Okay. So that's like your embedded care model. This pharmacist came from Meyer and spends half day a week in the clinic. And then he went back to half day a week in his pharmacy, but now we've moved him back to 2 half days in the clinic so he can get to know 2 of the other docs. So you got some docs in on 1 day, some docs in on another day. He was doing really well, I'll say pretty well with a few docs. And now we need to get him exposure and trust with some other physicians. Then this year, we added a young woman from an independent pharmacy into a clinic. Now, keep in mind, all 3 of these clinics are with the same physician organization. So I've got a similar medical director at a higher level, but each one of them still has a medical director in their clinic. Each one of those clinics have quality, people focused on quality so that we can go to them for data. Okay, so that's a positive thing. Next year, our 1817 folks at MDHHS did not want us to expand our model. So see, we have 3 pharmacies, that's it in our 1817 project. But what they want us to focus on is how can we identify a set of physicians and physician organizations who are poised to do this type of work in what would be year 4. Because we're hoping CDC is going to come down the road with something that's similar around team-based care. So we're trying to tee ourselves up for team-based care around more physicians and more physician organizations. So what can we do to begin to build those partnerships, i.e., let's get these docs that we work with to come talk to more docs and tell them about the experience with their pharmacists. So here's what we're going to have: patients seen, visits billed, hypertension controlled, and high blood cholesterol treated. Okay, that's in theory what we have. Okay, so let's see what we really have. Okay, so the Michigan model for primary care says that a pharmacist sees 6 patients in a half day. 6 patients in a half day of clinic. So if our pharmacists are spending 1 whole day in clinic, 2 half days, but 1 whole day, you would expect 12 patients a day. If I just said 8 patients a day for a quarter, that would be 100 patients. Because I'm just put 100 on there. And you can see this is where our pharmacists are. Not so much. Not so much. So clinic 1 has 32 patients over 50 weeks. Okay, so that's the blue. So she started, she got better, and then not so much. And you're all saying, Karen, Farris, what are y'all doing to support them? And I'm going to show you in just a moment, okay? And you should be saying that. What are y'all doing? You're not helping these pharmacists. That's what you should be saying to me. Clinic 2 also did pretty well and is doing okay. And this is a function of him going back to the clinic, right? For a couple days. And then clinic 3, so she wasn't even started, okay? So she just started like right in here, okay? So this pharmacist, let me just be honest, she's our little star. She's not little, she's our star. She's not big, I'm being silly, sorry. Saying an inappropriate word. She's our star. So I want to point out to you that in Michigan, we are focused on billing care management codes, okay? So that tends to be G9002. We can bill that to Blue Cross, they will pay it. We can bill it to Priority Health, they will pay it. We cannot bill it to Medicaid, we cannot bill it to Medicare, okay? 2 of our clinics are rural health clinics, so they can bill G0511 for care management. And we're beginning to see that, okay? You are all probably aware of telephone assessment with these 989 codes. And so the longer you spend on the telephone with someone, you can bill for longer amounts of time. And then we are currently not billing MTM codes, but and you may have known this forever, but we just figured out that if we're in an FQHC or a rural health clinic, our pharmacists can bill the MTM codes through the clinic, not through the pharmacy, through the clinic. And you guys may have already known that, but we just figured it out. And so we're now going to be figuring out if in our 2 clinics, we can have our pharmacists also bill MTM codes, okay? So MTM codes are not going to fully cover a pharmacist's salary. They are going to help, but we have got to also add in that improvement in quality and the uplifts that a clinic receives because of those improvements in quality. And that is a tough thing to pull apart, for lack of a better term. What's the pharmacist's contribution? What's the nurse's contribution? What's the social worker's contribution? What's the physician contribution, right? And so that's almost impossible to tease apart. So then you've got to be thinking about, can you compare clinics that have pharmacists and don't have clinics? So then you've got to look at a big health system or look at a state of Michigan like we have in our quality collaboratives. So I think we have some opportunity, but it's going to be tough, okay? And there are those of you on the talk today that might have insights into that can help us. I see a question online that I should have answered earlier. Marie is asking, in that Meyer project and in our current, where we have the pharmacist in the clinic, the vast majority of recommendations are getting accepted because they're sitting in the EMR, right? So there's no pharmacist phoning to talk to a doc or phoning to talk to a nurse, but those recommendations are teed up right in the EMR, and the physician is accepting the vast majority of them and getting patients to blood pressure control. Okay, so even in our new clinic with our Meyer pharmacist, and what's critical about this is that at Michigan, that Meyer model was based upon like 15 years of having pharmacists in primary care clinics. So when you go to the physicians and you say, we're going to have these trained pharmacists in Meyer, they've been trained to act just like I do, Mr. Dr. Physician, you can refer your patients safely to that. There's a lot of social capital among the physicians to accept that, okay? When we think about the Meyer model in our 1817 project, we've got to get that pharmacist in the clinics to build that trust and build that social capital before they can go back to their pharmacy and make those recommendations through the record. Because if the physician doesn't know you, all of you in this room who are clinicians know it's almost impossible, right? So you got to have that trust. Okay, so I think that answered that question. Okay, so let me go back to what we've learned so far in our 1817. So what you asked me earlier in your head was, Karen Farris, what are you guys doing to support these 3 pharmacists? And so we have physician organization leadership from the top. We have the administrative director who met with all the physicians in those clinics. If you look at ERIC, which is all the list of implementation science interventions that you should do, I've got most of those. I've got some of those outlined here. You could even put more of them up here. We've got academic partnerships, funding for the clinical innovation. So this doesn't have to be done free to start. We've got training for the pharmacists. So this is a program where we bring the pharmacists to Ann Arbor. It's actually online and a little bit in Ann Arbor now, where we're training those pharmacists who came from community and who are learning how to manage blood pressure. And importantly, make the drug recommendation to change the drugs. In Michigan, we have a broad collaborative practice agreement. These pharmacists do not have a collaborative, but they can make these recommendations through the EMR, and the docs are going, yeah, that sounds good. All right. We've implemented workflow change after workflow change. Okay. So how is the MA getting them scheduled? How is the list being generated? How are the physicians doing referral? How are where are the visits with the patient being held? So we, as I said, PDSA'd this in the 3 different clinics in different ways because every clinic's different. Okay. But the point is, we've thought about it. We're not just saying, oh, pharmacists, go meet with these patients, because we know that won't work. Importantly, we have a clinical pharmacist who meets with these pharmacists at least monthly, so that they have clinical support about complex cases that they may be seeing. And then when I say that we have provision of local technical assistance, so that's the quality people that are already in the sites that are helping us with data and helping us with, I'll stop with data. In addition, there are, of course, billing people in each of those clinics who are helping us figure out how the pharmacist should bill. So there's local technical support in those 3 clinics to help the pharmacists. So I'm like, okay, if there are this many uncontrolled patients in these clinics, why aren't these numbers higher? Any ideas? Anybody got ideas? I don't have the answer, but what I said to Teresa yesterday is that you can have the context pretty good, aligned, right? And if you don't have the right person who's the go-getter, you ain't gonna get the go. Like, you still have to have the right mentality of this pharmacist to actually push a little bit, because these are rural docs that haven't been used to having a pharmacist in their practice. And admittedly, I don't think we on the project side did enough at the organization of the clinic to say what the pharmacist was going to do. And part of that was COVID, because we were all locked down. We couldn't go anywhere. We couldn't visit with people. And we relied on the PO staff, the PO folks, to tell that message. So, so I wish I could show you there's like hundreds of claims every quarter. I think we'll get there with one of our pharmacists. We might get there with the second one. We will not get there with the third one. And we need to do some qualitative interviews to understand why that is. So I don't have all the answers, except that context does matter. What you do in practice to support the pharmacist does matter, but it's also who you got at the table. It's not just who you got at the table either, though, okay? All right. That was what I wanted to say about our 1817 project, and I'm happy to answer any questions at the end. And can I just confirm that it is 18 till 1?
Yes.
Okay, thank you. All right. So here's question 3. Which of the following innovations in healthcare is most directly focused on sustainability of pharmacist care? Health IT, certification of pharmacy technicians, billing codes, new models of care, like appointment-based models, or this was from Objective 3, but I forgot the name of it. Which one do you think? Actually, now that I look at it, you might think 1 or 2 answers. Now that I think about it. Is it A?
No.
Sustainability. I'm going with no. I agree. Is it B? See, I'm kind of with Dave, no, but then I'm kind of with Voshko, maybe C. Yeah, so the answer is really C, okay? We've got to figure out that billing model to sustain any kind of innovative models. We've got to get the billing figured out, whether it's provider status and you can bill E&M codes, or in Michigan, where we're billing care management codes and we can improve quality, or you can bill MTM codes or some mix of that.
I think it's D.
It is not D.
Because appointment-based medicine doesn't require billing. It actually saves money on.
So this is appointment-based model for pharmacists. So how can a pharmacist run an appointment-based model if they don't have funding?
We'll save money, but
So this would be a question that you could contest on the exam and write me some notes, and I would look at it at the end of the semester. If your grade was going to change by answering this question correctly, then I would review it for you, Dave. Okay. I'm saying it's C. All right. Okay. I want to talk really briefly about linking primary and specialty care in something we call PCOM. And so this is, I didn't even spell out what it is. What I can tell you it is we have primary care pharmacists linking with oncology pharmacists for people who are new OAA starts. Okay, somebody gets a new OAA. We want to do a PROM, a patient reported outcome measure on them. We want to link that to the oncology pharmacist. Then if they have chronic conditions, we want the primary care pharmacist to do a CMR to understand what the implications of that OAA are for the patient's chronic conditions. And then have those 2 pharmacists talk. So that's where we're coming from. And so these are our pilot data, the percent of follow-up in CMRs among participants with the new OAA. In our pilot data, we had 96 people, 55 had a CMR, 1 in 4 needed follow-up with the physician or with the pharmacist. Actually, that's 1 in 5, okay? 1 in 5 needed follow-up with the pharmacist and a physician. So there's 2 different buckets there, okay? So this just said to us, there's something here, we need to do something about this. Can we link primary care and oncology pharmacists? And so this is our complex diagram from our forthcoming publication about what we're doing. So real quickly, a person gets a new OAA. They complete a patient-reported outcome measure on day 14 that goes to their oncology pharmacist. By day 28, we've completed a CMR. A couple of weeks later, we're doing another PROM. So we're trying to be proactive out of the medical office to get patients on a new AA to report the symptomatology that they're having. And that goes to the oncology pharmacist, but the connection with the primary care pharmacist is if there's any problems with medication interactions. Are the OAAs going to cause problems with hypertension? Are they going to cause problems with diabetes? And we know that some of them will. And so how can we get those two linked? Teresa yesterday was telling me that you guys have got an oncologist who just immediately sends one of their patients to one of your primary care pharmacists to take care of the diabetes. So that's a perfect model, right? Whether the patient goes straight to the pharmacist or the oncology pharmacist is talking to the primary care pharmacist, or we have another model at Michigan where we have a primary care trained pharmacist who went into the oncology practice and helps manage the symptoms and has learned those meds, but is also focused on primary care conditions. So we can do this in a variety of ways, but we think it's important to begin to think about this. These are our outcome metrics that we're assessing. And let me just be really, really honest. We started this study in the middle of COVID. No, we didn't. We started this study right as COVID came about, and it just stopped us. It just stopped us. We couldn't recruit. We couldn't figure out how to recruit. Nobody was coming into Michigan medicine. And so we're just now getting started back up. But I wanted to tell you about the concept of linking specialty and primary care for people, new OAAs and chronic conditions. Yes.
This paper is a model setup.
This is in our forthcoming publication that I did not reference, but yes, this is in our forthcoming publication.
And it's the model without the results.
Correct. It's a protocol paper.
Okay.
So we have a protocol paper that is accepted. So what?
What journal?
It's the RSAP one that's for clinical protocols, but I don't remember the name. That one, ER. Yes. Yes. Thank you. I hope Shane is not online and didn't hear me say that. Okay. 3 minutes to Q&A, seriously? Let me have 7. Okay, 3. Here's what I've learned. COVID killed recruitment. We're just now starting again. But really, pharmacists are pharmacists. They are not researchers. They will not recruit for you. They will not. So just bottom line, we tried, they wanted to, it just doesn't work. And like I knew that, but then they said they could, it just doesn't work. But now we've got it worked out. We've got an RA screening and then another RA phoning. So it's all good. But really, pharmacists are pharmacists, not recruiters for your study because they're too busy. Final. We've started a remote blood pressure project. This is an effort to have our university, our College of Pharmacy, take interprofessional teams to the Ann Arbor Housing Commission, which is low-income housing in Ann Arbor. You guys have already got this down. VCU, you've got this model set up. We are just starting in Michigan. So that's where I said, that's where I'd like to do some follow-up. So we have a pilot study. I do think importantly, we're using a new blood pressure monitoring device that is cell-driven, not Wi-Fi driven. And so then we see the dashboard, we see the results, and then we're texting people about their blood pressure. The most important thing that I have learned in 2 weeks of activation of this study is this. In the building, we have a person, Penny, who lives in the building, resides in the building, and who is our peer support person. She is our study advocate. So she is checking in with people, making sure they know how to use their device, answering questions that they have, texting me, emailing my RA. She looks like them. She is one of them. She knows what blood pressure is. We trained her on blood pressure. She knows how to use the device. She's already used the device with 2 people. So we have 4 in our study because we just started last week. We got 2 more coming in this week. And one person already had high blood pressure, went to the doctor and already has a new med. So peer support. So when I heard about your health hub and your difficulty in getting people into the diabetes, the DPP, you got to get to your churches. You've got to get to your schools. You've got to get to other organizations that can help you build relationships to send people there, for lack of a better term. Okay, so you need to work and find people to be on your study team who are community leaders. And so in an African-American community, that's going to be a church leader. Get them on your study team. Pay them some amount of money to help you. And you're going to build referrals over time. Okay, just a couple more slides and I'm really done. Let me just say, after 4 participants, we already need new text messages. Like we had text messages about different levels, but when you've got 3 readings that are high in 1 week, we didn't really think about what do you do with that? And so we've already had 3 high levels in 1 week. So our new protocol is call the patient, talk to them about A, B, C, and D. So this is a pilot to learn how to do this. And that's what we're doing. Okay. I have to keep moving. So because there are students here, I have to answer this question. How many years have I been studying pharmacist care? So look here. You can't see this, but what that says is 1993. That was my first publication. Okay, my first publication, 1993. So that means I was in grad school in like the 90s. So I've been doing this almost 30 years, folks. I'm really old. But what's the coolest thing about pharmacy is that I published these papers. In 2003, I'm sitting in my office at the University of Iowa, and this guy right here sends me an email and invites me to the National Congress on Pharmaceutical Care in Granada, Spain. So in 2003, I go to Granada, I give a talk. We then, Fernando, I meet Charlie, who is the dean in Australia. We put together pharmaceutical care and community pharmacies around the world. We probably have about 10 publications from different countries around the world that we edited and got published in Annals of Pharmacotherapy. All because I wrote these 2 papers in grad school. Okay, and then some very nice person emailed me. Then we built a new relationship. Okay, then Teresa corrected me. She told me that in 2009, I came to Portugal. I kind of forgot that. But in 2010, I definitely went to Portugal to ISPW, and I definitely met Teresa there. Although originally, I guess I'd met her in 2009, but I forgot, so I apologize. So I knew Teresa. And then in 2014, I get this phone call. From who? This guy right here, Fernando. Karen, Teresa needs to come do a postdoc with you. What you got? Pretty much, that's what he said. And I'm like, bring it. So I went to Spain, interviewed Teresa. She did miss a Justin Timberlake concert just to come meet with me, which I do think is a big deal. She missed Justin Timberlake, still kind of kills me to this day. But anyway, 2 great years with Teresa. This is the result of our work. And now here she is, being a terrific assistant professor and leading up your center here at Virginia, VCU. And I do have some advice for students, but I'll do that next meeting. And I want to thank these people here. These are my collaborators. This is in my primary care work. This is in my OAA work. And then this is in my Ann Arbor Housing Commission work. So with that, I have to stop talking. And you saw I had too many slides. So I appreciate your attention. And I'm running over and I have 6 minutes for questions.
There's a few questions in the chat.
Oh, here it is right here. What is your long-term global vision about the engagement of pharmacists in the corporate chain drugstore industry, mostly in patient care and minimally in their traditional medication supply function? What is the most important barrier to achieving that vision? You got a week? My true reaction to that is that we will have few structural outlets for drugs in 20 years. They will be mailed, droned, whatever the right word is, directly to individuals out of central dispensing hubs. We as pharmacists must be telehealth providers, folks. And we will need to be in medical offices because there's still going to be a touch for patients, for sure. But I think that's primarily going to be, this is Karen Farris's vision, primarily in a physician office. And we're buying OTCs from Amazon, they're being delivered. We're getting all of that kind of thing brought to our homes. Okay, that's Karen Farris's vision. I could be wrong, right? I could be wrong. What's the most important barrier to that? I'm not sure there are barriers to that vision. I think there are barriers to maintaining the brick and mortar, and just the business model. I just don't know if it's going to be there. Dave probably has very strong opinions about that, Boschko as well. So that'll be an interesting conversation. Another community-based referral source for HBP research, yes, is through hair salons and barbershops. Great point, great point. So I know that when I was in Iowa, we were doing a project on oral contraceptives, and we were in Black salons because women are sitting there for several hours. And so the stylists were talking to their clients about OCs and use of contraceptives. So, and we know barbershops are a place where people are going for blood pressure control. That was a randomized trial. So great, great point. I work for, I think, Virginia Pharmacists Association, and we are working on an 1817 with a large emphasis on CMM. That is excellent. Can you elaborate more on the ACE training? How many hours in person or virtual? I can send you that link. That link on my slides is active. We would love to have your pharmacists come and participate in that. It's 3 days. It was originally 5, now it's 3 days. And it may all be virtual. It certainly turned that way in 20 and 21. I'm not sure about this June session. So does someone have Karen Winslow's contact for me, and I can send her that link? Okay, great. So Karen, I will send that to you because it would be a great resource for you guys to at least take a look at and see if your pharmacist would like to do that. Okay, I got all the questions on chat. Oh, there was another one. I thought it was just. I'm good. That was a long-term vision. That was like the very difficult question. Slides will be shared. If you heard things that you think you can help us with, I did not put my email here. Teresa will have my email. Please email K Farris, like a Ferris wheel, but with an A. KFARRIS@umich.edu. I would love to hear from you. I think we're doing some fun things on the research side at Michigan. Of course, Michigan Medicine is doing all kinds of brilliant things in the AmCare space. I think my time is up. Thank you. Am I talking to the grad students in this room?
Yes, that's your next one.
Oh, perfect. So just leave those slides up.
Oh, not in this room.
Oh,
I thought you meant like two-dimensional. Thank y'all for being here today. We will post this recording and the slides on the website later this week. And I will get to see it sorted out. So you'll receive many emails from me. Thanks, y'all.
she said, y'all.